Good afternoon, ladies and gentlemen. Today, we have all gathered here for the CPC of this month. As we all know that every case in CPC which is discussed has resulted in not a favorable outcome. Today's discussion will be on a patient who was with us for quite a long time, I should say around 61 days, a serving soldier. Who had multiple comorbidities along the sequence of his hospital admission. We will go through it, that how things went from one thing to the other and resulted in his demise. Today's presentation will be divided into two parts. The clinical part will be discussed by Colonel Naresh Bansal, Senior Advisor Medicine and Endocrinologist of Command Hospital, Southern Command. Whereas following that, the pathological discussion will be carried out by Group Captain Pragya, who is Prof. Pathology and Oncopathologist of AFMC. With no more delay, I request Colonel Naresh to start the proceedings.
Good afternoon, everybody. My clinical presentation will be based on the clinical protocol which has been provided to me. And I want to tell that the clinical discussant was not involved in the management of this case. So we have a 39 years old male resident of Karnataka who was admitted to our hospital on 24th of September and succumbed to his illness on 23rd of November 2024. During this illness, he was admitted to the nephrology ward and to the medical ICU during this entire course of the illness. So he had initially presented in July 2021. He'd initially presented in July 2021 with loose stools and tenesmus. Sigmoidoscopy done at that time showed an ulcerated stricture in the rectum, and the scope was not negotiated beyond this stricture. A contrast-enhanced MRI was done, which showed an asymmetric growth 2.3 centimeters from the anal verge, extending for length of 13.9 centimeters, with enlarged lymph nodes in the mesorectal fat, enlarged bilateral, external-like and internal-like lymph nodes. Histopathology of that biopsy, which was taken, had shown a poorly differentiated adenocarcinoma of the rectum. So with this diagnosis, when adenocarcinoma was detected, he underwent neoadjuvant chemoradiotherapy. From October 21 to November 21, he underwent 28 cycles of radiotherapy. From December 21 to July 22, he underwent chemotherapy, 8 cycles of chemotherapy. And in January, he underwent abdominoperineal resection and a colostomy was done. Intra-op finding revealed a circumferential growth in the lower one-third of rectum with invasion to the coccyx, and histopathology revealed poorly differentiated adenocarcinoma of the rectum. The lesion was resected and a diversion colostomy was made. However, he developed neurogenic bladder post-surgery. If we see the CA levels at the time of diagnosis was low. However, it kept on increasing over the period of time, and it was always around 200 during this entire course of the illness. So since his CA levels were high, he was kept on very close follow-up and he was evaluated repeatedly. In July 22, a CT scan was done, which showed a soft tissue lesion in the pelvis, likely granulation tissue with fibrosis with obstructive uropathy. Now, cause of obstructive uropathy was thought to be radiation-induced ureteral stricture, and he underwent bilateral DJ stenting. In October 22, a PET scan was done, which showed a metabolically active FDG-avid intraperitoneal lesion in the pelvis. It was opined as a residual disease with central area of necrosis in the presacral region or an organized collection. So we have a patient who underwent abdominoperineal resection and colostomy in January 2022, and July he had obstructive uropathy with bilateral DJ stenting, and in October he had developed a collection. So in October 22, his exploratory laparotomy was done and the abscess was drained and ileostomy was also done. In February 23, a PET scan was repeated, which showed that the lesion had resolved completely and there was no abnormal FDG avid uptake anywhere in the body. December 2023, again a PET scan was repeated, which showed that the lesion had resolved completely and there was no abnormal FDG avid uptake anywhere in the body. It was repeated again in June 2024, which shows that there was a mild FDG avid lesion in the presacral lesion at the level of SV3 to SV5. He had developed neurogenic bladder post-surgery. He was on intermittent self-catheterization since February 2022 after the surgery, followed by indwelling Foley's catheter. He had developed bilateral hydrouteronephrosis in July 2022 and underwent silicone degestenting. And because of this neurogenic bladder, he had bladder voiding dysfunction because of the damage to the nerves, which are very common in abdominoperineal resection and a very large mass when it is operated. If you see the neurogenic bladder post-surgery, neurogenic bladder occurs in about 5.5 to 16% of the patients undergoing rectal cancer surgery, and the risk factors include male sex, older age, tumor location in the lower rectum, abdominoperineal resection, laparoscopic surgery, low visceral fat mass, and deep pelvis. And our patient also had number of risk factors to develop neurogenic bladder following the abdominoperineal resection surgery. He had recurrent pyelonephritis with bilateral degestant in situ requiring repeated courses of antibiotics. Right degestant was changed on 19th of April 24. Left was deferred in view of difficult approach. He had developed chronic kidney disease stage 5, which was non-oliguric, non-dialysis dependent. He had bilateral hydrouteronephrosis and pyelonephritis with degestant in situ, and he had slowly progressed from stage 2 to stage 5 chronic kidney disease. So if we see the timeline of the past admissions, in July 21, he had initially presented. He was detected to have carcinoma rectum, underwent surgery and chemoradiotherapy. In July 22, he had developed obstructive uropathy, underwent degestenting. Then in October 22, he had developed a pelvic abscess, which was drained and ileostomy was done. In February 24, he had developed complicated UTI and pyelonephritis and acute and chronic kidney disease. And in September 24, this was a present admission. So when he had presented to us on 24th of September 24, he had presented with complaints of pain right flank, dysuria, pyuria, recurrent vomiting, and fever of 2 days duration. There was no history of cough, breathlessness, chest pain, decreased urine output, facial puffiness, diarrhea, altered sensorium, or seizures. On examination, he had a toxic look, he had tachycardia, blood pressure was 98 by 66 millimeters of mercury, tachypnea. He had a non-functioning left AV fistula, which was created on 12th of June 2024. He had pallor. Abdominal examination revealed a ileostomy and colostomy in both iliac fossas, Foley's catheter, and right renal angle tenderness. Other systemic examination revealed only tachycardia. There was nothing else. Investigations revealed a hemoglobin of 8.7, TLC of 10,700. He had marked azotemia with a creatinine of 8.3 mg%. Earlier in April, his creatinine was 4.2. Electrolytes were within normal limits, and urine routine examination showed a turbid urine with numerous pus cells. He had hypoalbuminemia, and ultrasound abdomen revealed bilateral grade 4 hydrouteronephrosis, right more than left, enlarged right kidney, and thinning of cortices. So the initial diagnosis at the time of admission, what was made was a sepsis, complicated urinary tract infection, acute and chronic kidney disease, neurogenic bladder, and a poorly differentiated adenocarcinoma of the rectum. He was managed with fluids, hemodialysis, and antibiotics in the form of cefoperazone and levofloxacin. And other conservative measures were continued. A bit about hemodialysis and hemofiltration. I'm discussing this in brief because these are very important in the management of this case, and the patient had undergone multiple modalities of therapy during his course of treatment. There is hemodialysis in which the solutes pass through the dialysis membrane, and there is hemofiltration in which the water and solutes pass through as a result of the positive hydrostatic pressure. And how do we do the dialysis? There are two kinds of dialysis, high efficiency and a low efficiency. In low efficiency dialysis, a lesser flow rate is required. So this does not require a AV fistula to be made. But a high efficiency dialysis requires a very high flow rate, and an AV fistula is required for a high efficiency dialysis. On 24th, he was admitted. On 27th, he had persistent fever, flank pain, dysuria and pyuria. Urine output was adequate. Antibiotics were upgraded on 27th to meropenem and levofloxacin. Over next 10 days, his general condition and hemodynamics improved. He became afebrile. There were no urinary symptoms. On indwelling, he was already on indwelling catheter. Leukocytosis resolved and azotemia was persistent, requiring intermittent dialysis. However, on 7th of October, there was recurrence of severe flank pain and fever. There was sudden decrease in the urine output from 1500 to 100 ml, hypotension requiring vasopressors, no breathlessness, anemia, and increase in the TLC count. So we have a patient who had carcinoma rectum, chronic kidney disease, neurogenic bladder, prolonged catheterization, who had come with acute pyelonephritis, suddenly developed sepsis with septic shock. For a person who had initially responded with a sudden deterioration in the shock, the possibilities which were considered was, is there a recurrence of pyelonephritis because urinary catheter and DJ stents was already in situ? Is there a stent obstruction or a stent migration, or there is associated myocarditis because of infection already undergoing in the background of other illnesses which he already had? Investigations revealed anemia, a TLC count of 43,000 with 93% polymorphs with toxic granules and toxic vacuoles. Marked azotemia, electrolytes were normal, procal was raised 27.9, ABG revealed high NN-gap metabolic acidosis, chest X-ray revealed non-homogeneous opacities, ECG also showed changes in the form of Q waves in V1 to V3 and TROP-I was raised. A CT abdomen was done because of his deterioration, which showed that there was no evidence of any degestant migration. So what was reported was a grade 4 hydronephrosis, right greater than left, enlarged right kidney, extensive perinephric and periureteric fat stranding, and loco-regional lymph nodes. A 2D echo was done in view of ECG changes and raised TROP-I, which showed that the LV ejection fraction was normal, and the 2D echo did not show any region of wall motion abnormality. If we see the hemoglobin, he was given packed RBCs transfusion. TLC count had increased. Initially, he was started on cefoperazone and levofloxacin, which was upgraded to meropenem and levofloxacin, with which he responded. Later, now when he had deteriorated, he was started on colistin, tigecycline, teicoplanin, and antifungals in the form of caspofungin. He was continuously undergoing, initially he had undergone maintenance hemodialysis, but thereafter he was started on low efficiency dialysis. So what we had was now the possibilities which we were considering initially was a recurrence of pyelonephritis. Is there a renal abscess which has formed because of which he has deteriorated? There was no degestant obstruction, there were no degestant migration, and there was no myocarditis. So now he was managed with continuous renal replacement therapy, packed RBCs transfusion, antibiotics has already been upgraded to colistin, tigecycline, antifungals were also added. He was also started on steroids, hydrocortisone in view of septic shock. The response to the treatment was very poor. He did not respond. There was persistent high-grade fever. He had hypotension requiring 3 vasopressors in maximal doses. So in view of persistent high-grade fever and pain abdomen and oliguria, he was advised MRI abdomen. Now MRI abdomen revealed bilateral dilated calyces, and D1 weighted ADC images were suggestive of pyonephrosis. Now what the radiologist told us that when the hyperintense signal changes to hypointense on ADC images, it is suggestive of pyonephrosis. A urology intervention radiologist consult was sought for PCN. Patient underwent right PCN, 200 ml of greenish pus was aspirated, left nephrostomy was not done, and the PCS got decompressed on its own. He developed severe tachycardia, tachypnea, hypotension, and desaturation post-procedure. 2D echo ruled out pulmonary embolism because of hypotension, tachypnea, and hypotension. We suspected pulmonary embolism. 2D echo, however, ruled it out. He was continued on fluid resuscitation, vasopressors, elective mechanical ventilation, renal replacement therapy, packed RBCs transfusion, and antibiotics and antifungals. Steroids were continued. Pus biofire revealed E. coli and Candida albicans, and blood biofire revealed methicillin-resistant Staph aureus and Stenotrophomonas maltophilia. Along with hemodialysis, there is something called as a cytokine filter. He was also, this filter was also used in order to decrease